So our next talk today is from Dr. Wade Pullin. Wade's a medical oncologist trained in Brisbane, Queensland. He's the oncology fellowship at Royal Brisbane. He did his oncology fellowship at Royal Brisbane and Women's Hospital. He's a staff specialist for the last 10 years at the Gold Coast University Hospital, so didn't have to come too far today at all. He's a senior lecturer at Griffith University School of Medicine and subspecialises in neuro-oncology. Wade's going to talk to us today about an update on rare CNS tumours. Thank you, Wade.
All right, thank you for the opportunity to come and have a chat to you all today. So I always talk a little bit about myself as well too at the beginning. I think it's important to put a little bit of yourself into each presentation. So I'm a clinical oncologist. For what that means is it's the application of studies and science into the real world. So I oversee the clinical trials as well too and manage patients on them, but I don't design the trials and I don't do any laboratory work, and nor am I going to do so. So I was a psychologist before I was a physician. So a lot of that colours my background and some of my talks. So I can get a little bit waffly sometimes, so I apologise for that. And I'm also renowned for not doing what I'm told. So if I've gone a little bit off topic, tough. So there's a lot to discuss. So there are a lot of really rare tumours, and I can't talk about them all today. It's not possible. There's too many. It is one of my interest areas, though, is doing all sorts of rare tumours, including sarcomas and young adults as well. Sorry, I can't read that thing down there. It's too small for me. I'm getting too old. So I've selected a few, I think, that have a few specific updates and something that are a little bit more interesting to talk about. So let's talk a little bit about hemangioblastomas. So what are these things? These are rare, slow-growing tumours of the brain or spinal cord. They're made up of many small blood vessels, so that's where hemangio comes from. It means blood, and blastoma is tumour. They are often benign and not cancerous, but they can cause serious injury because they press on things. Rather than invade into them, they tend to squash things to the side a little bit or move things a little bit out of the way. They're often found in the cerebellum, part of the brain that controls balance and coordination, but they also occur in the spinal cord and the brain stem. So von Hippel-Lindau syndrome. So not everyone will have heard of this because it isn't common. So it's people with VHL syndrome inherit a change or mutation in a gene called VHL. This gene normally controls cell growth. And when it doesn't work properly, cells can grow too much and form tumours, often in the brain, spinal cord, kidneys, pancreas and eyes in people with this syndrome. The faulty VHL gene can't switch off the specific protein called HIF, hypoxia-inducible factor. And that is kind of like a growth switch. Especially when oxygen's low, it tells the body to make more blood vessels to help the cells survive. So in VHL tumours, HIF stays switched on all the time, never turns off, even when oxygen is normal, no matter where you are. And that constant signal encourages tumours to grow and develop their own blood supply. So that's where it makes these little blood vessel tumours. It just keeps growing and growing because it doesn't know to turn off. Many people with VHL develop multiple tumours throughout their lifetime. Traditional treatments generally mean repeated surgeries to remove these. If they're benign, you just have to keep trying to take them out. But as I suspect everyone in the room knows, our brain stem and our spine are pretty important areas, and leaving them alone as much as possible is what we'd love to do. So there's a new drug called belzutifan. Offers a non-surgical option that controls tumours a lot more gently than having an operation to remove it. It doesn't cure VHL or its related tumours, but it gives patients more time and a lot fewer operations. Is something we hope more for the future. So this is one of the things I like about this, because this is the whole point of community, which I think is a very important thing that we're already speaking about today, about how people change things in brain cancer. So during March and April of last year, Neuroendocrine Cancer Australia supported the people with von Hippel-Lindau syndrome garner as many signatures as possible for a government petition to list this new drug, belzutifan, to be part of the public benefit scheme, because it's not cheap. It's very, very expensive. Almost 18,000 Australians signed it, and belzutifan became available in December last year. So now we have a drug that can actually work where we had nothing in medical oncology for this before, essentially. And it's changed things enormously, and we now have 2 patients on those locally, and one of them who is only just started, another one that's been on it for a few months. The difference has been enormous. It's made a huge difference to his life. So then I want to have a little talk about craniopharyngiomas. So this is also another rare, slow-growing brain tumour. It's usually benign and not cancerous, but can still cause serious problems by pressing on important parts of the brain again. It occurs in both children and adults, most often diagnosed between 5 to 14 years, or people over 50. They're found near the pituitary gland usually, a small gland at the base of the brain that controls hormones, and often very close to optic nerves, which carry vision from the eyes. So options are always surgery to remove as much of the tumour as possible. Often they can't remove it all, it's pretty common. Radiotherapy with high energy beams to control remaining tumours behind, and hormone replacement if the pituitary gland is affected. The most common subtype of craniopharyngiomas is known as papillary, and about 90% of these papillary craniopharyngiomas harbour a gene mutation called BRAF, which we've heard a little bit from Angela already today about BRAF inhibition, which it kind of acts like a stuck accelerator pedal in tumour growth. It's a mutation frequently found in melanomas, as we've already heard, which we use specific drugs to target in the melanoma setting. So what are BRAF and MEK? So this is what we talk about. These are some of our drug targets that we use. And we've got a little thing there with the tumorigenesis pathway, which just kind of says cell growth to tumour cells. And they pass through all of these different chains of signalling. And we have drugs that can attach and attack at different parts of these pathways. So BRAF and MEK are proteins in the chain of signals inside the cell known as the MAPK pathway. And that controls cancer growth. Well, can very much control it. So in BRAF mutant tumours, this chain is overactive. And so BRAF inhibitors are medicines that block the faulty BRAF protein directly, and they stop or slow the growth signal. And MEK inhibitors work one step further down the chain, and they help strengthen the efficacy of the BRAF inhibitors to prevent resistance as well. So we use them both together, BRAF and MEK inhibitors together. And this can shrink tumours, improve symptoms like vision or pressure, and sometimes can be used before surgery to make the operation safer, or when surgery or radiation are not enough to deal with the problem. So benefit-wise, a more targeted treatment focused on the tumour's specific mutations, and that can reduce the need for repeated surgeries or radiations again. Limitations, not all craniopharyngiomas are BRAF positive or have this mutation. And the side effects might include skin change. We know they can include skin changes, fevers, tiredness, and eye and heart effects that we have to monitor very closely. And long-term use is still being studied, but we've been using these for years in melanoma. We're all very comfortable in using these drugs. So it's something we certainly can do. So there is some small trial data, but it is very exciting. It made a huge difference in things, and will do in the future. I'm quite sure of it. So BRAF, there's a little study there done in the New England Journal of Medicine, which is a very popular journal we use for oncology. A small study of 16 patients. 15 out of those had a durable objective response to therapy. And the tumour reduction on median was 91%. So that wasn't little, that's really big. But the range being from 68 to 99. So someone had almost a complete response, and someone only had about 70%. But to me, that's enormous. That's not little. And one person didn't get a response. The only reason they didn't get a response is they couldn't tolerate the treatment and stopped it after a few weeks. So everyone that was on this treatment for any extended period of time had a huge reduction in size. And whilst that's a very small study by oncology means, we do have other small studies like that in rectal cancer where they're using immunotherapy that are similar to this, that have had a huge responses and made an enormous difference. I think that's on my next one. So we've got the drugs in Australia, and we're experienced in using them. We know how to use them. We know how to deal with the side effects. We know how to manage this. They're not available on the public benefit scheme. And as you'd imagine, with all drugs, they're not cheap either. But for craniopharyngiomas, they are available for melanoma. And I know there's a big phase 3 study coming because it's a rare tumour. It just takes time to get it done. And this certainly may make it very available for people in the future. As I keep yelling at my neurosurgeons, is we should be giving this before your big operations, where then you don't need to do a big operation, you do a small one. And that'll make a huge difference to people's lives. So I'm very excited about that, but can't do it yet, but coming. But it is available on TGA, so if people have a lot of money or people want to work very hard, kind of like they did for belzutifan, and make a difference and try and get things like this on the PBS, I think it will certainly help. I sure as hell will be happy to give it, and we will all be very comfortable doing so. So then I want to have a talk about NF2 and schwannomas. So what's neurofibromatosis? So this neurofibromatosis 2 we'll talk about specifically is a rare genetic condition again. It causes tumours to grow on nerves in the brain and spinal cord. It can be peripheral as well too. The tumours grow from Schwann cells, which normally wrap around and protect our nerves. And in NF2, multiple schwannomas can develop all throughout the brain and spinal cord. And again, they don't invade, but they do squash and push on things and cause problems and symptoms. They very commonly affect the hearing and balance nerves, called vestibular schwannomas. And they can appear on either cranial nerves or spinal nerves, so where the main nerves come off the upper end of the spinal cord and bottom of the brain. So as I said, they're benign, but their locations cause big problems for patients. So bevacizumab, this is probably something anyone also involved in gliomas will know something about. Also used to be called Avastin, as its trade name. And this can induce both tumour shrinkage and hearing improvement in patients with NF2 associated vestibular schwannomas. And there's growing experience in big multidisciplinary neurofibromatosis treating centres in the United States, where they're using bevacizumab as a first-line therapy, even before any operations, for vestibular schwannomas. Because if there's any big threats to neurological function and you need a big operation, as anyone here will probably tell you, that can cause a lot of problems having a big surgery. And again, if we could shrink that down before we do anything, that could take away the need for radiation or minimal need for radiation or a larger operation. So we'll talk a little bit about bevacizumab because I use this quite a lot in my practice. So it's a type of targeted cancer medicine, again, for those who haven't had experience with it. It's sometimes called an anti-angiogenic drug, anti-against angiogenesis, making new blood vessels. And as you probably thought, if you're thinking about it, hemangioblastomas are like this, so maybe this will work on that. I know it does sometimes because we've done it. So it's an anti-angiogenic drug. Why blood vessels matter in cancers. So tumours need their own blood supply to grow of any sort. And the blood vessels bring the oxygen and nutrients that feed the tumour. So more blood vessels, faster and bigger tumour growth. That's the theory anyway. So this targets and blocks a protein called VEGF, vascular endothelial growth factor. And it's kind of like fertiliser that tells the body to grow new blood vessels. Except in this case, we're kind of turning it off is what we want. So it sticks to the VEGF, stops it from sending the grow more blood vessels message. And reduces tumour blood supply, and with less oxygen nutrients, it may shrink or grow more slowly. Can control tumour growth, may reduce swelling around the brain tumours, improving symptoms like headaches or vision, and often used together with chemotherapy and other treatments. It doesn't cure cancer. It helps manage it and its side effects. Side effects may include high blood pressure, bleeding and clotting problems, and delayed wound healing. That's not suitable for everyone. Some people just can't have this for other reasons. But generally, it's extremely well tolerated. My goodness, I give this stuff every single day. And even though it does cause some problems, they're usually quite rare and quite minimal. And it doesn't make you sick at all. Most people have the infusion and don't notice a lot of the time. It's really, really common. So until recently, bevacizumab was expensive and under restricted PBS guidelines, significantly limiting the way that we used it. We could only use it in very specific settings. It's now completely unrestricted on PBS. As long as I've got evidence, I can use it on whatever I like now, which is fantastic because that's exactly what we should be doing. It's well known for its role in managing pseudoprogression and edema or swelling in glioma conditions, and has applications in other non-malignant conditions as well too. Well, this is kind of what we're talking about here. So we'll do that before we get to Omega. So I have 2 young gentlemen on this with neurofibromatosis who've gone from wearing enormous corrective lenses to not wearing glasses at all anymore. And one young man had no use of his left arm whatsoever, who now can move it wherever he likes and has pincer grip back. No fine motor, but in him that's made an enormous difference to his life. And he goes on and off bevacizumab because what he has is not technically a cancer. And because bevacizumab is unrestricted, he can go on and off it whenever he feels like it. Like sometimes he says, I've had enough of coming. I want to take some time off. I'm going to do something for 3 months. Then I'll come back and my symptoms are coming back because it's regrowing, and he goes on it again. So it makes an enormous difference and costs nothing. It's very cheap now, even if people needed to buy it, which you don't in Australia now. Omicocast, we touched briefly on this, so I wanted to chat about it because I think it's really important for everything. So what is Omicocast? You've already heard it bandied about. So it stands for the Omics Institute for Cancer Research in Australia. And it's the goal is to bring advanced genetic testing and clinical trials to people with cancer. So what's CASP? It means the Cancer Accelerator Study Program. Offers genomic testing, which is a DNA test, to all cancer patients. Now, they only accept patients with malignancies because they've, unfortunately, I have tried quite a number of times and gotten away with it with non-malignant conditions, which I treat a lot of, but they've cottoned on to that now and say, no, this isn't technically a cancer. You can't do this anymore. So what do? They get a sample of the tumour from surgery or a biopsy, and it's sent for special testing. We look for the genes in the cancer cells are examined using advanced technologies that we have now. Results are shared with the medical team who look for possible targeted treatments and trials. I think the best way to think about this is it's probably a bit more than that. So what it does is there's usually one centre or 2 in each state which will coordinate all of this. So they don't need to see you in person. They can do it all over the phone. Then they will coordinate to get your tissue sent to them, to their lab for testing, and there's a separate lab in each state. Then when they get all the results back, they sit down at a thing called a tumour board, where a whole bunch of people who are very learned in this area from all different walks, not just clinicians and researchers, have a look at it and then compare those results with trials that are available that are all in a big database. Then send out an email to me that says, this is what we recommend, this is what we've found. These are some trials that might be an option. And sometimes they send out in the game, sorry, we've had a good look, there's some mutations, but there's no trials and no drugs available for those targets. So it helps match people to new medicines and new trials. It may open doors for treatments not otherwise available or thought about. And I think most importantly, this is an investment in the future because it's then looking at everyone's tumours. So even if people may not get a result that they want, that might help someone else down the track where we identify mutations where there have never been one before because they're looking at about 450, I think it is, different genes. So they just do this huge blanket of them and then look for mutations in different tumour types. So I think that in the long term is definitely the way forward, is tailored medicine. As I said, doesn't always find a match. And sometimes, frequently, the best option is still the standard of care. And we use the results alongside, not instead of regular medical advice. I think it's important as well too, there's still a lot of companies, even in America, and I'm sure they'll be here at COGNO showing up all there with their little booths, where you can pay for this, but you can get this done for free in Australia without having to go anywhere except having one blood test and having one phone call. They will do it faster in America, so they can get a turnaround in about 1 or 2 weeks, whereas this often takes 6 weeks to 3 months. But there's very few patients, I think, that can't wait because this is more, I think, a long-term thing, not a very beginning first-line thing. So even though we feel the need to rush and that spending $2,000 or $3,000 will help speed that up, I don't think that will change anything, and we can do it for free, and it's Australian. Next generation sequencing. So advanced DNA testing again, it reads and analyzes many genes at once, faster and cheaper than older methods. So this one's a lot faster than OncoCasp. So why do we use NGS in gliomas? Every tumor is different at the genetic level, and it helps us find gene changes that inside a particular person's tumor. And these changes can give us clues about the way it behaves and which treatments might work best. For anyone who knows about gliomas, MGMT is one of the fastest ways to do it. As well as this gives us a whole other bunch of different targets and prognostic markers as well too. So we want to find mutations and rare mutations that I'm going to get to, and we've already touched on just a little bit. So it helps to avoid a one-size-fits-all approach. As we know, for any type of higher grade glioma, we haven't changed a lot in the last few decades, so it's good that we're trying to do something different. That's why I'm very keen on it. And may open access to clinical trials and other research therapies that we're looking for, because not every gene's got a treatment yet, and it may not lead to new options, and it still needs expert interpretation and follow-up with your regular oncologist. So again, another good thing. In Australia, next generation sequencing for diagnosis and classification of high-grade gliomas only, it can only be glioblastomas at present, is available in Australia on Medicare rebate from July 2023. There's a very small, that's an understatement, number of pathology labs able to do the test. So it requires your local pathology centre to forward your tumour material onto another centre after they've looked at it and made your diagnosis and suspicious of high-grade gliomas. So it should be routinely done on all suspected high-grade gliomas to look for important mutations. It doesn't cost anything to your hospital. It's paid for on Medicare by the federal government. Everyone who has a glioblastoma should get this done, I think, as a standard of care from now on. I recently presented a few weeks ago at the Society of Neurosurgeons in Australia, and I was a bit shocked that a lot of them didn't know that this happened, because their pathology centres were not doing this for them, and they should be, which now they all know. That's the good thing about that, at the very least. So they will go home and make some changes. So some rare mutations in gliomas then. So this one's already touched on briefly, so I won't spend a long time on it. NTRK fusion therapy is what we call. So these are rare, but they can be major drivers of tumours. And larotrectinib is a targeted therapy drug designed to block tumours caused by these NTRK mutations. It's kind of like putting a brake on the faulty growth signal again. They work pretty quickly. It's really impressive. Not that it's very common, but the few patients we have on them, it makes an enormous difference. It can be used in both children or adults if they have the fusion. And I would even sometimes say you probably don't need some of the other more common treatments if you've got one of these mutations, and wait and see what happens. That's a bit controversial, but I like to do that. It's more precise targeting tumours with this, and it's now available on the PBS for rare gliomas. So if you have this mutation in Australia, you can get this drug. You don't have to pay for it. But people have got to test for it. So if you're not getting a next-gen sequencing, you're not finding out whether or not this drug may be accessible. But everyone should be getting tested. It's not common, a mutation, though. Like I said, this is why I've got the rare tumours talk, because it is not a common mutation. And it's not only in gliomas. You can use larotrectinib for other cancers with NTRK mutations in Australia as well. FGFR mutation therapy. This is another tumorigenesis pathway. Again, where it just starts at the tops. Things say grow, move down these different pathways of proteins, and then we can find areas where they attack. So again, another very rare mutation. And the FIGHT 209 trial, specifically looking at gliomas with this mutation, over previous basket studies, including everyone, have shown efficacy in gliomas. It's not available on the PBS, but it can be purchased, as the drug is available in Australia, and it is very expensive to buy. But there is, I believe, a cost share program to some extent, but it's still very, very expensive. But again, if you're testing for this, OncoCasp is looking for FGFR rather than NGS, and this is where we've had a few patients on this. It's not quite as effective as larotrectinib, but again, I think tablets and targeted agents are better than chemo any day of the week. That's easy. So things have changed a lot since I've been doing this in the last 20 years. It's more about personalised medicine now and working out the right thing to do. And there's a lot more global collaboration, which enables trials to recruit across the globe and find treatments for rare tumours, which is what we want to do. And I think it's an exciting time to be living in at the moment. There's a lot of changes in a short space of time, so I find it really interesting. I get very excited about all this. So I get to have my little plug here too as well at the end. So this is my take-home messages. They're challenging, but research is growing, especially with Omicocasp will make a very big difference and already has. Community support's vital. That's why I think days like this are really, really important, where we can all come and share and have a chat thing and ask questions. Because like with belzutifan and VHL, it makes a huge difference. Where there was no treatment, now there is some, and it's completely covered. It's marvellous. I loved it. And all grade high gliomas should be assessed by NGS. People with rare tumours should discuss with their oncologist regarding Omicocasp testing for rare mutations and trial matching. It's free. It doesn't require much effort from individuals. And always ask with your oncologist about new options and trials. But discuss about the pitfalls with ease with your oncologist as well too. We spruik, I think, too much with phase 1 trials. You have to be willing to give up a lot to be part of a phase 1 trial. You give up a lot of time. You give up a lot of blood. You give up a lot of things doing scans, and we don't know if it's going to work at all a lot of the time. That's one thing I always tell everyone, all my patients, is happy to refer you, happy to think about it, but you really got to think you're going to give up a lot. And are you going to miss out on things that you otherwise might have been able to do with time that may not be as long as you want? So that's something you always got to take into account. But any oncologist should have a good chat about that with people, see what's right with them. So shameless plug. Oh, I'm excited about this. So we have completed startup for IPAX 3 Bright at Gold Coast University Hospital. We were ready to go last month, which I was going to spruik at the neurosurgical meeting, and now we're having an issue with the machine calibration. Everything else is done and we're ready to go. So I didn't do any slides on this one, but I could talk for the next 20 minutes on it, but I'll better not. So this is in high-grade gliomas who have progressed post-standard therapy and using iodine 131 attached to a LAT3 receptor. This is all big words for saying it's using the same sort of treatment as we use already for thyroid cancers, using radioactive iodine, but it crosses the blood-brain barrier. And this is for recurrent glioblastomas, and this is a phase 3 trial, not a phase 1. This will be open in all major centres around Australia in the coming months, but Gold Coast should be first. I'm hoping by the end of this month we're up and open, and we will be the only place in Australia, unless someone beats us because of our stupid machine. Anyway, that will make a huge difference because there's not many good solid trials for high-grade gliomas, especially not phase 3. And for anyone thinking about it, so it is not a you go on, you get the drug. It is a randomized trial, so you get randomized to standard chemotherapy versus chemotherapy plus this agent. And there are always a few sacrifices for this because it's radioactive. You have to spend 3 or 4 days in a little lead-lined lock room with nurses and doctors coming to see you while we give you that treatment, but then you're free after that. But that is the first big trial that I'm very excited about in my career, I think, for glioblastomas. I think this is something, having seen the earlier phase studies, has a chance to make a very big difference in some people. Some people it won't help, but some people it will, which will be a big difference. So I'm really excited about that open very, very soon here. So when we have a little chat, I'm an oncologist, ask me anything. So when we're on, if you have any questions about anything, I'll answer pretty much anything you've got. I really don't mind, okay?